Hi, everyone, and welcome back to another episode of hashtag C Arthritis. In its 12th year, I could not be happier to be in the studio on the heels of her defense of her poster, Dr. Kayla Chubbs. Welcome to the studio.
Thank you for inviting me.
So, we've had so many people in the hot seat before you, and we'll have a few more in the hot seat after you, Dr. Chubbs. Let me take a minute to introduce you to our audience, and then we'll dive into our conversation. So, for our audience, Dr. Kayla Chubbs is a resident in the rheumatology program. So remember, rheumatology means arthritis at Dalhousie University. She completed medical school at Memorial University of Newfoundland and internal medicine residency at Dalhousie University. Following completion of her training, which is just around the corner, I'm sure she's very excited about this. Dr. Chubbs plans to work as a rheumatologist in New Brunswick. Dr. Chubbs's research interest includes rheumatic, immune-related adverse events, and medical education. Don't worry, you don't have to know what all those words mean now, but at the end of this brief interview, you're going to know. So welcome to the studio again, Dr. Chubbs.
Thank you.
Yeah, so you were here at the annual scientific meeting, not just to learn yourself from your colleagues attending the scientific program, chatting it up amongst your colleagues in the poster sessions. You also were presenting a poster, and the title of your poster, Validation of the Health Assessment Questionnaire Disability Index in Immune Checkpoint Inhibitor-Induced Inflammatory Arthritis. So I said that without making one mistake, which means I get
You
a
did
gold
great.
star on my report card. But you're going to break that down and tell our audience about the poster and what you learned from it. But before we go there, tell us just a little bit about yourself. Tell us about your training and how that's gone and what you most look forward to.
Hmm. So, as you previously mentioned, I'm a rheumatology resident. I'm in my fifth and final year at Dalhousie University here in Nova Scotia. And my two favorite parts about my job is number one, the patients. In this specialty, we really get to see patients over the course of their lifetime for many, many years. And we really build a strong relationship and connection and have that continuity of care. So that's one big draw of why I chose rheumatology. And the second piece that just makes my job so enjoyable is my colleagues. We have such a collegial group across the country, which was evident at CRA ASM this year as well, that you always can rely on your colleagues to talk about the complicated cases and to ask for advice and to bounce ideas off of one another. And I really enjoy working in that kind of climate.
Yeah, it's interesting. We also really enjoy, we meaning patients. I live with
Mhm.
rheumatoid arthritis, as I've mentioned to you before, for many, many years. And it is that bond that you form
Mhm.
with your rheumatologist and other members of your care team that is very special. And I will say to our audience, rheumatologists spend more time with their patients on initial visit, on complicated follow-up visits. You make the time for us, and we're so appreciative of that. We can't wait for the day when science has major breakthroughs and learns how to turn our diseases off, and we can say adios to you, frankly. We'd rather not have our relationship with you. But we're so happy that there's such a caring community in rheumatology. It is so amazing as a patient and also as someone who works in arthritis to be able to work with you. So it goes two ways, Dr. Chubbs. What about your poster? Um, so patients fill out forms who live with autoimmune forms of arthritis literally the entire course of their disease. So
Mhm.
yours is kind of related to the health assessment questionnaire, one of them that we fill out a
Mhm.
fair bit. But how does that relate to this specific therapy, which we've been hearing more and more about,
Mhm.
checkpoint inhibitor induced or checkpoint inhibitors? and then
Mhm.
how they might induce inflammatory arthritis. So I'll stop there and tell us what your
Sure.
poster tried to do, who you
Mhm.
did it in, like who did you work with in terms of your study population, and what did you learn?
So, immune checkpoint inhibitors are cancer therapy that has really taken off and is steadily rising in use over the last number of years. So, it's used across multiple different types of cancers. And the thing about these treatments that affect the immune system, they, while treating the cancer, can unfortunately put your immune system into overdrive. So it can induce an inflammatory arthritis that you've never had before. Or, like yourself, if you've had a diagnosis of rheumatoid arthritis or an inflammatory arthritis, it can worsen your already pre-existing disease going on these therapies. So for us, we know that inflammatory arthritis can significantly impact your quality of life and your function, in particular in the cancer population as well. It's a twofold impact. So these questionnaires that we use in rheumatology clinic, like the Health Assessment Questionnaire Disability Index, they haven't been validated in this particular type of arthritis. So that was the purpose of this study, to see if this is a helpful patient-reported outcome measure that we should use to measure function in these patients. And I'll tell you one more nuance between this particular type of inflammatory arthritis compared to other types of inflammatory arthritis, like rheumatoid arthritis. So in rheumatoid arthritis, our goal is treat to target. So remission, that's the
Yes.
goal. In the immune checkpoint inhibitor induced inflammatory arthritis, we really have to balance the amount of immunosuppressing medications because we know the more immunosuppression can negatively actually impact the cancer treatment.
Wow.
So it's a fine balance between the two. So instead of treating to remission in this population, actually function might be a better target. So not how many swollen or tender joints you have, not what your inflammatory markers are doing in the blood work, but are you able to do the things that you need to do in your life? And maybe that should be our target in this population.
So super practical measures,
Mhm.
not so much the hard clinical measures that you as professionals often look at. It's really fascinating, Dr. Chubbs, that, if you look at two therapies I can think of off the top of my head, methotrexate,
Mhm.
a cancer therapy from way back, still used in cancer, some forms of cancer treatment, but is highly effective in the treatment of rheumatoid arthritis, for example. So this is a therapy that has crossover application,
Exactly.
but it doesn't, when used in cancer therapy, does not trigger or induce an inflammatory arthritis. Yet, these checkpoint inhibitors in
Mhm.
some patients can trigger the onset of inflammatory arthritis. Do we have any idea why one does and one doesn't? Is it because the checkpoint inhibitor is that much more powerful?
It's just a different mechanism of action of the drug. The term checkpoint matches up within our immune system. There are certain gates that open or close to prevent a cascade of effects from occurring. So that's what these particular drugs are targeting, is those gates,
Okay.
whether they should allow the cascade to occur or whether they shouldn't, which is very different than, say, methotrexate, which might have just a more broad target. It's not such a targeted agent as these checkpoint inhibitors.
I see. Okay, that makes a lot of sense. So when we think about the poster and the things
Mhm.
that you learn in the poster, so what does that mean for this group of people? So this isn't all types of inflammatory arthritis. This is inflammatory arthritis that was induced during a
Mhm.
cancer treatment protocol. So for these people, what does your poster mean? What what can they learn and how can it improve their lives?
So, to give you a sense of how often this is occurring, this immune checkpoint inhibitor inflammatory arthritis, we think 11% or more of patients on this immune checkpoint inhibitor therapy are getting this. And it's actually the number one reason why these patients are sent to rheumatology for assessment and management. And in many of these patients, it can become chronic, meaning even once the immune checkpoint inhibitor therapy is stopped, the arthritis might not go away and might persist for many, many years. So significant impacts on a patient's function and quality of life, even if their cancer is entirely treated. And if they're in remission for their cancer, they might be living with this chronic arthritis now. So how how we measure function in rheumatology clinic is important. The health assessment questionnaire disability index. You probably recall filling out some of these yourself,
I
but
do.
what it looks at is 8 particular categories of function. Walking, dressing, bathing are a few of them. And then there's adjustments in the score made for whether you need to use an assistive device for any of these activities. And then the overall score is an average of all of the categories. And so the lowest score you can get is a 0, the highest score you can get is a 3. So the higher the score, the more your function is impaired. And it's helpful to monitor whether your rheumatologic disease is improving or worsening over time. So in this population, it can help us target our treatments based on what's going on with the overall patient's function and help to guide management decisions of how do they need further escalation of therapy, or is their function actually acceptable for them that we can withhold immunosuppressive therapy and let them continue on their immune checkpoint inhibitor for a little bit longer to get the best cancer outcome as well.
Yeah, that's I mean that I keep when you first said, oh, it's a teeter-totter of
Hmm.
trying to figure out how we get rid of the cancer and how we, you know, then subsequently try to manage the inflammatory arthritis. Of those 10% of the patients that are being treated with a checkpoint inhibitor for their cancer and then go on to develop an inflammatory arthritis, does the inflammatory arthritis in those people, Dr. Chubb, does it last? Is it, I mean, because there are some types of inflammatory arthritis that can be episodic. You could have one episode and it might go away. Does that happen often, or is this a population that where it sticks with you?
At least half of patients is
Okay.
sticking with them.
Okay.
So it's like getting a diagnosis now of rheumatoid arthritis, and it just so happened it was induced by this treatment.
Right. Okay.
So then you're living with this chronic condition afterwards.
Yeah. So super important for folks who may be going through this therapy, if they do experience some of those classic signs and symptoms, they're obviously being followed closely in their treatment by their cancer specialist. And then that, if they present with symptoms that are classic symptoms, signs and symptoms of inflammatory arthritis, then you're saying, Dr. Chubb, they get referred then to see a rheumatologist. Um,
Yes.
okay, so this year's, I mean, I can think of nothing worse than going through a cancer treatment and then being told you have inflammatory arthritis.
Mhm.
However, there are excellent treatments for inflammatory arthritis post the cancer experience,
Mhm.
and it can be suppressed such that you can live a relatively normal life if you remain on therapy. So, want to offer some promising news to folks who may find themselves in this position. Tell us, Dr. Chubbs, this year's meeting, it was very appropriate that it was in Halifax, and obviously they played on that geographical location by choosing a theme this year called Shifting Tides, Embracing Change in Rheumatology. So you're young, you're new into the profession. What do you see as shifting tides in rheumatology? What are you seeing right now? I mean, I've spoken to so many of your colleagues who have
Mhm.
been in the profession for 40 years during
Mhm.
this year's hashtag C arthritis event. And they pull back in their memory bank quite a ways. But for you, someone who's new into the profession, what do you see as shifting tides and the kinds of change you see happening?
So, staying on topic with really this overlap between oncology and rheumatology, really we're seeing these immunotherapies or immune checkpoint inhibitors being used for more indications and just continuing to expand. So, we're seeing more of these rheumatic immune adverse events, and inflammatory arthritis is just one of them. There can be a number of other rheumatologic conditions induced by these treatments. But what we saw at this year's CRA ASM is the CAN-RIO group, the Canadian Research Group of Immuno-Oncology, in collaboration with the CRA, released guidelines over the last year on management of pre-existing rheumatic disease in the context of immunotherapy. And there's also a part two to these guidelines as well, which is really helpful, I think, for both providers and for patients to know that more and more research is being done in this field. And we're having expert opinion guidelines created to help direct care.
Yeah, so we actually have a new piece of our community. It's that Venn diagram where we're having patients that are coming, people who are living with both cancer and arthritis and other types of diseases. And this actually has been around, this problem, if you will, has been around for a long time because there's so many different kinds of diseases that are concomitant or off there. We have comorbidities. So if you
Mhm.
have osteoarthritis, you may also be struggling with obesity, and therefore you may be struggling with diabetes, and therefore you may be struggling with heart disease. So there's probably lots of overlap across a lot of different communities, but you're suggesting this one with people who are on the immunotherapy. That's a shifting tide, and
Mhm.
and we need to figure out what we need to do to our treatment paradigms to address those. So super exciting area that you're working in. Do you plan on continuing on this area of research once you finish your rheumatology training?
I hope so. I'm very grateful for my research mentor here in Halifax, Dr. Janet Roberts. She is part of the CAN Rio group and the principal investigator on this project. And she has been an amazing mentor to me as a junior researcher.
That's amazing. It's always I have found over the years in my work with the Canadian Rheumatology Association and rheumatologists in general that once someone develops a focus area, it literally can take you through your entire lifetime, and you become the go-to person on checkpoint inhibitor therapies and induced forms of arthritis. So, congratulations, Dr. Chubbs, on your poster, on the work that you've been doing. But most importantly, welcome to the community. From the patient side of things, we are very happy to see you coming into the field because you know what the rheumatology demographic looks like. There are many who are nearing the end of their career, so we're so thrilled to see someone not, I don't want to say fresh-eyed, but newly minted, let's say that, with all of your experience already to begin practice. So, congratulations on both the poster and your impending graduation, I guess, if you will. We
Exactly.
wish
Thank
we
you.
wish you the best of luck, and I look forward to interviewing you at next year's meeting. I'm sure you'll have lots to say then as well.
Thank you so much.
Thank you. And thanks to our audience for dropping in on this incredible interview with Dr. Kayla Chubbs. Come back. We'll have another interview shortly. Bye bye.